Thank you, Alan, for the warm welcome. I'm very excited to be here today and to have the opportunity to present some of the work that I've been doing over the past 10 years. So in contrast to conventional meta-analyses, which I'll assume you are all familiar with, these pull together published results from eligible reports, individual participant data meta-analyses, or IPDMA analyses, which I will be talking about today. They synthesize the participant level data from different studies instead, so actually getting the raw participant level row by row data. So these types of meta-analyses are challenging to conduct, in particular due to the resources needed to identify, obtain, and harmonize the relevant data, but they do have many benefits. So for instance, in an IPD meta-analysis context, you can standardize participant inclusion criteria and outcome variable definitions. They also increase the analytical flexibility because you have the data in your hands. And in the IPD context, you can also start to address research questions that cannot be easily addressed or may even be impossible to address using only published aggregate results. So in this presentation, I'm going to focus on this latter use of IPD meta-analysis projects, and this is in the context of psychiatric epidemiology. And I'm going to present a series of projects that have used large IPD databases in order to illustrate and examine some important problems in mental health assessment research, including research on depression screening, as Alan mentioned before. So depression is common and disabling, and it is associated with a poor prognosis. I assume that you're all familiar with the concept of mental health and depression. And because of this, depression screening is often recommended, even though it is quite controversial. So the goal of depression screening is to identify individuals with unrecognized and untreated depression. There we go, so just getting the pointer ready. So looking here at this figure on the left, let's assume that the pink stick figures have depression, whereas the greenish gray ones do not. So the idea with depression screening is to create the perfect net that captures all or most of the individuals with depression. So we want to capture all of the pink individuals with our net without falsely identifying too many individuals who don't have depression. So we try to not, we're trying to avoid capturing these greenish gray individuals with a net and just capture the pink ones. So this is done using depression screening questionnaires, such as the one you see on the right. So this here is the Patient Health Questionnaire 9, or the PHQ-9. And it's basically a multiple choice quiz where there are several questions. So in this one, there are 9 items. And for each item, you respond on a Likert scale, depending on how you've been feeling over the past 2 weeks. And this is used to determine who receives a further diagnostic assessment for mental health. So depending on how you respond to the 9 items in the screening tool, either there'll be no further assessment, or if you screen above a threshold, there will be a further diagnostic assessment. If appropriate, a diagnosis can be made and treatment can be offered. So in order to evaluate whether or not these screening tools are accurate at identifying individuals who have depression, we conduct studies where we evaluate what's called the diagnostic test accuracy. So in these studies, everybody in the study will be administered both a screening tool, so this is the depression screening questionnaire, as well as a diagnostic interview. So a clinician will evaluate them and determine whether or not they meet the clinical criteria for depression, and they'll have a diagnosis of depression or no depression. And then you put everyone in this 2x2 table. So based on their screening results, so screen positive or negative, and their diagnostic result, depression or no depression, you get this 2x2 table, and you can calculate sensitivity, specificity, and positive and negative predictive values using simple formulas. And one particular nuance in the contents of depression screening is that our screening tool is this questionnaire that has a range of possible results. So you kind of get this continuous score of 0 to 27 on the PHQ-9, and you have to define where you're going to call a positive versus negative screen. So you might decide that 10 or above is a positive screen and 9 and below is a negative screen, or you could use a higher threshold such as 15 or 16, or maybe you want to use a lower threshold. And depending on where you draw the line, the distribution of participants in your study are going to change which boxes they're in. So your estimates of accuracy are going to change depending on the cutoff threshold that's used. Okay, so in the first part of the talk, I'm going to talk about some of the limitations of the diagnostic accuracy evidence for depression screening. And then later on in the talk, I'll show how IPDMA analysis allowed us to overcome that. So one of the main issues in primary studies and conventional meta-analyses on depression screening accuracy is that this concept called selective cutoff reporting. So this is a conventional meta-analysis that was published in CMAJ in 2012, where they combined data from 18 studies that evaluated the PHQ-9 depression screening tool. So each of these studies reported sensitivity and specificity for one or more of the cutoffs in the possible cutoff range. And then for every cutoff score, they pooled together the accuracy results for the studies that had reported data at that cutoff. So you can see that a cutoff score of 10, which is considered the standard cutoff of this tool, 16 of the 18 studies reported accuracy results, but at the other cutoffs, there really wasn't that much reporting. So at cutoff 7, only 5 of the 18 studies reported accuracy. Similarly, at a cutoff of 12, only 10 of the 18 studies. So you can see that different studies tend to report different ranges of the spectrum. And the problem is seen over here. So if we look at the accuracy at cutoff ranges of 8 through 11, as the cutoff threshold for having a positive screen increases, so you have to have more depressive symptoms to be considered a positive screen, the pooled sensitivity was found to increase, but this is mathematically impossible. But it's due to the fact that different studies were contributing to the different analyses of the different cutoffs. And again, this is a problem in conventional meta-analyses. A second problem in conventional meta-analyses, and as well as in the studies contributing to them, is that there's a lot of studies that are done with very small samples, and then they use data-driven methods to identify an optimal cutoff. So just to give you an idea of the sample sizes, the typical depression screening study only has about 200 participants or fewer. And among those, only 30 or so will have depression. So when you're calculating sensitivity, which is done only among the cases, because sensitivity is done among cases and specificity among non-cases, your sample size for sensitivity estimates is typically less than 30. So really not very robust. And even so, with these small samples, different studies can sometimes identify divergent optimal cutoffs, and they'll attribute their different optimal cutoff to study or participant characteristics, not necessarily to the small sample sizes. So here are just a few examples from papers that I've come across in my work. So there was one study that reported that for the Thai version of the PHQ-9, they recommend a cutoff score of 9 or greater. But this was based on only 19 depression cases. So again, really small sample size for sensitivity. Another study reported that in the Chinese population, a cutoff score of 7 or more is recommended. So again, this is quite different than 9 or the standard of 10. And even though this study had over 1,000 participants, there are only 28 cases of depression. And finally, a third example, one study done among participants that had diabetes found that a cutoff score of 12 or more was recommended. And not only did they recommend this higher cutoff, but they attributed it to clinical characteristics, stating that patients from a specialized diabetes clinic have more severe pathology and more complications, which could be recognized by the PHQ as depression symptoms while instead being diabetes symptoms. And this is why the higher cutoff threshold is needed. But again, here we have only 37 cases of depression that were used to estimate accuracy. Another problem we've seen in the literature is that there's different types of reference standards. So the gold standard for our 2 times 2 estimates, and they're typically both considered gold standard and lumped together in evidence syntheses. So one type of diagnostic interview or gold standard is what's called a semi-structured diagnostic interview for major depression. So these interviews must be done by a clinician, therefore they are expensive to administer, and there's a scripted list of questions that are asked, but there's some flexibility in follow-up, and the clinician can use their judgment to determine whether or not a particular individual meets criteria for major depression or not. On the other hand, there's also what's called fully structured diagnostic interviews that are completely scripted. So there's no more clinical judgment component. And because of this, they can be done by a lay interviewer, meaning that they are less expensive to administer. But because they don't have that clinical judgment component, they may be less valid. So they may not be as good at distinguishing between individuals who do and do not have depression. But again, typical meta-analyses have considered both of these as equal gold standards and lumped results together. Another limitation in the evidence is that there's a lack of subgroup analyses, so looking at whether or not accuracy varies depending on age, sex, country, setting, and other characteristics. And this is because typically the individual studies, the primary studies that are done are too small and don't have the power to look at these characteristics in their study. And if they're not reported in the primary study, then it's nearly impossible for meta-analysis to pool the results for accuracy based on these types of characteristics. And finally, another limitation of the diagnostic accuracy evidence is that there's this binary approach to screening, even though that may not be the best use of information. So here we have our continuous screening scores ranging from 0 to 27, and we put some cutoff threshold where we say everybody below the threshold is a negative screen, likely not depressed, and everyone above the threshold is a positive screen or likely depressed, and you're assigning the same probability of depression to everyone above the tool in the same, probability of depression to everyone below the tool, the cutoff, and again, when you dichotomize a continuous variable, there's a huge loss of information, and this is really not recommended, but this is how screening tends to be done. So this is something where we can maybe do some better work. And finally, just stepping away from depression screening, but still in the realm of mental health. There's this problem of estimating depression prevalence based on screening scores. So ideally, if you wanted to estimate the prevalence of depression in a sample of interest, you would administer a validated diagnostic interview. So a clinician would, do a thorough interview among everybody in your study, and you could estimate the prevalence of depression. But because this would take a lot of time and a lot of resources, many researchers will administer self-report screening questionnaires instead, and then they'll say that the percentage of participants who score above the screening cutoff is the prevalence of depression in that sample. And this is wrong. Again, this is akin to saying that the percentage of women with a positive mammography is equal to the prevalence of breast cancer. And again, we would never say that in a cancer scenario, but somehow in mental health, we tend to take this percentage of positive screens and infer prevalence of diagnosis. And just to substantiate this, my team conducted a meta-research review where we looked at 69 meta-analyses. So we did a review of meta-analyses where each of them did a meta-analysis of depression prevalence. And out of the 81 prevalence estimates, only about 10% were based on the diagnostic interview. So 10% are using the right method. And then all of the other meta-analyses either use screening tools only or a combination of screening tools and diagnostic interview. And the pooled prevalence in these meta-analyses was highest when based on a screening tool and lowest when based on the proper method of diagnostic interview. And it's intuitive that prevalence would appear to be higher if we're using screening tools and thresholds rather than a formal diagnostic interview. So given all of these limitations, there's really been a need to conduct IPD or individual participant data meta-analysis in order to improve the quality of research in this area. So with all this in mind, in 2012, the Depression Screening Data Project, or the DEPRESSD project, was born. And DEPRESSD is an international collaboration that aims to synthesize the global evidence on the accuracy of different depression screening tools by conducting individual participant data, or IPD meta-analysis. It's a large project. We're coming up on our 10-year anniversary in February, which is quite exciting. Over the past 10 years, we've been awarded 11 CIHR project grants to work on research in this area. We have a huge team consisting of 10 steering committee members who are experts in either the method side of IPD meta-analysis or the clinical side of mental health or psychiatry. We also have knowledge users who contribute to different screening tools in the different clinical areas. We have over 350 data contributors that have provided us with their raw patient-level data to put into our IPD meta-analysis databases. And a local team of over 20 students and staff that work together on a day-to-day basis, putting together all of the databases and harmonizing the data to be able to have this rich database. So far we've been funded to look at 4 different depression screening tools. So the PHQ-9, which I've mentioned a few times already, and most of my examples come from this screening tool, as well as 3 other tools, so the EPDS, the HADS-D, and the GDS. And overall, we have data from about 300 studies representing about 100,000 participants and about 11,000 cases of major depression. So a really rich resource for conducting research in this area. And just before I get into some of the studies, I'll just talk a little bit about the data that we have. So just like a typical systematic review meta-analysis, we identify eligible studies in literature or through correspondence and the grade literature. Once we identify these studies, we transfer primary data. So we actually get, again, the row by row, patient by patient data, and then we convert all of the data into a uniform format. So we end up with a master database that has study level variables and participant level variables. So at the study level, everyone in a given study might have come from the same country, they were recruited from the same setting, and they will all receive the same diagnostic interviews, the same gold standard. But we also have more nuanced information from each participant. So each participant is a row in our master database. Each participant has their personal depression screening score, their personal major depression diagnostic status. And there's also other information such as their sociodemographic and medical variables, so age, sex, medical comorbidities, and other things that may or may not be related to mental health and to potentially the accuracy of these tools. Okay, so this is a bit of a long introduction, but just to put everything in context. And in the rest of the presentation, I'm going to go through a series of projects that have used IPDMA analysis to illustrate and overcome some of the limitations in depression screening and assessment that I mentioned earlier in this talk. So I'll start off with selective cutoff reporting. And here, this study was published in the American Journal of Epidemiology in 2017, and it was actually the pilot study for the DEPRESSD project, and it was my master's thesis as well. And so what we did here is we compared conventional meta-analysis to IPDMA analysis by collecting the patient-level data from a set of studies and then doing both traditional meta-analysis of published cutoffs only and IPDMA analysis using information from all cutoffs from all studies. And we also looked at the patterns of cutoff reporting in each of the primary studies. Okay, so you can see here there were data from 13 studies included in this paper. So for each of the individual studies, we shaded in gray the cutoffs that accuracy were reported. So this study, Stafford, they published results for cutoffs of 5, 6, and 10. So again, these are the gray is what was reported in a particular study. And the O is the optimal cutoff that maximized the combination of sensitivity and specificity. And there was a really clear pattern that if a low cutoff threshold was optimal in a study, then the authors tended to report on the lower end of the cutoff spectrum. So we see a lot of shaded area over here. Whereas if a higher cutoff threshold was optimal and worked better in that specific study, then the authors tended to do the opposite. They would report cutoffs on the higher end. So really the reporting is matching what was optimal in the study. Now, this doesn't seem so bad on its own, but I'll show you on the next slide what happens when you try and put this information together in a meta-analysis. So here you can see the results of two types of meta-analyses. So on the right, we have all data. So this is the IPD meta-analysis context, where we have all the information combined regardless of what was published. And you can see that as the cutoff threshold increases from 7 all the way to 15, our sensitivity decreases and our specificity increases. So this looks great. This is what we expect this type of ROC plot to look like. However, if we're limited to just the published information, so pooling only the estimates that were published in individual studies, our ROC plot looks like this. So sensitivity is going up and down like a roller coaster. And again, this is mathematically impossible, and it's hard to come up with, a clinical conclusion over here because it's just a mess. Here we can see similar information but presented in a more quantitative way. So these are the different cutoff thresholds and then accuracy differences based on using conventional analysis and published cutoffs only versus using the IPD. And for cutoff thresholds below 10, sensitivity was always underestimated. And for cutoffs above 10, it was always overestimated if you're just looking at what was published and not at the entire picture. And interestingly, specificity tended to be pretty similar across the two methods. And it's not too surprising that sensitivity is more effective than specificity when the sensitivity, again, is calculated among cases, and our individual studies tend to have, let's say, 10 to 15% depression prevalence. So there's way more non-cases than cases. So we're getting a lot more skew in our sensitivity estimates. And we've repeated this study recently by pulling together PHQ-9 studies and EPDS studies, about 50 studies from our updated databases. And we did a similar analysis comparing IPDMA analysis to conventional meta-analysis, and we found similar results. So again, this idea of selective cutoff reporting, not good, but IPD can come in and correct for it, which is nice. The second project I'll present is looking at data-driven methods in small primary studies. So what happens when we use these data-driven methods in small sample sizes. And we see, results reported that for the Thai version, we need the cutoff of 9, but in the Chinese population, we have to use a different cutoff score of 7. So what we did to look at this was we conducted a simulation study using data from our DEPRESSD IPD database. So what we did was we conducted the simulation study to explore the variability in optimal cutoffs, as well as bias in the accuracy estimates when we use data-driven methods in small primary studies. So we considered that our PHQ-9 IPD database was a hypothetical population. So ignoring, the fact that it's all coming from different studies, but we said, assume this is one large population. I think there were about 20,000 participants in this hypothetical population. And in this population, we know that the optimal cutoff is 10, and it has a sensitivity and specificity of 77 and 85% at that cutoff. And now from this hypothetical population, we drew 1,000 samples of different sizes with replacement from the big database. So we drew 1,000 samples of size 100, 200, 500, and 1,000. And then in each particular sample that we drew, we determined the optimal cutoff in terms of maximizing sensitivity and specificity. And then for each sample size across all the different samples that have been drawn, we compared the optimal cutoffs identified and their accuracy estimates to those from the full IPD database. So again, to those from the hypothetical population. So here's what we found. I'll focus first on variability and then on bias. So here's what we found in terms of variability. So in samples of size 100, the individual samples that were drawn from the same population had optimal cutoffs ranging from 3 all the way to 19. And again, this is all from the same population, but we're just doing repeated samples from the same population, and we're getting a really wide range of optimal cutoffs identified. With larger sample sizes of 1,000, this variability is reduced. So in samples of size 1,000, the optimal cutoffs range from 6 to 12, so a much narrower range, although still not just the one optimal cutoff. There's still some variability. And this is what's known as a sampling distribution of statistics. So it's not, again, it's not too surprising that we're going to have some variability in primary studies if we're sampling them from a population and we have small samples. Okay, in terms of bias, so here we have sensitivity and specificity, and the dotted line represents the true value of sensitivity and specificity from our hypothetical population. And then our boxes show the averages of the sensitivity and specificity from our samples and their optimal cutoffs compared to this truth. And so specificity similarly affected, again, it's a small reduction, so -4%, so an underestimation of specificity of about 4%, regardless of the sample size. But sensitivity, again, is where all the problems are lying. And in small samples of size 100, which are, again, they're not atypical in this clinical area for research studies. If you have studies of only 100 participants, on average, you're going to be overestimating sensitivity by about 10%, which is pretty huge. With larger sample sizes of 1,000, this gets a little better. So here we're only overestimating by 5%. Again, it's still not perfect, but you can see that with larger sample sizes, there's less bias. So all these results from the simulation study are in line with what we've seen in our large clinical IPDMA analyses, where we looked at the accuracy of different depression screening tools. So here are just some screenshots of 5 different depression screening tool accuracy studies that we've conducted using our DEPRESSD databases. And all of our IPDMA analyses, we found that the accuracy of our tools does not vary substantively based on participant characteristics. So these things like whether or not, age or gender matters, or recruitment setting. And even though the primary studies may be making claims that they do, we're finding that overall, when we do these large IPD meta-analyses with really large sample sizes and robust analyses, that these characteristics don't seem to matter so much anymore. So it seems more of an issue related to small sample sizes and variability than due to clinical characteristics influencing the accuracy. Okay, moving on, we'll talk a little bit about this idea of imperfect reference standards. So if our gold standards maybe not so gold. So comparing different types of reference standards for major depression classification. So just to paint a picture in your minds, let's imagine a hypothetical patient named John, who's a 24-year-old male, Canadian, no medical comorbidities, and he scores 12 on the PHQ-9. He's administered with a semi-structured diagnostic interview, and he receives a diagnosis of no major depression. So no depression in this case. Now, in a parallel universe, we have the same John, so the same patient profile, same age, gender, etc. And in this parallel universe, instead of a semi-structured interview, he receives a fully structured interview instead. And this time he has a diagnosis of major depression. So this is not right. If we have the same John and the same, clinical profile, we shouldn't have a different diagnosis depending on the interview that was used. And this is what we tried to now study using our IPD database. So what we did is that we used our PHQ-9 IPD database to evaluate the association in between interview method and major depression diagnosis, while controlling for depressive symptom severity, so the PHQ-9 score, as well as participant characteristics such as age, sex, country, and setting. And the general idea here was to emulate the RCT design. So because every participant in the sample only had one interview or the other, and we want to compare the two interviews. So we kind of balance everything out. So the only difference between the participants in our model is what interview was used to diagnose depression. So here are the main findings. So this is a bit of a complicated figure. I'll just walk you through it. The y-axis is the proportion that were diagnosed with major depression in their interview. And the x-axis is the PHQ-9 score, which again could be considered a proxy for depression symptom severity. So these are the scores of 0 to 27, higher scores, more severe depressive symptoms. So, and these three lines here represent three different types of diagnostic interview. So for all of our interviews, we find, the slope is going up. That's good. We find that as the depressive symptoms get higher, more participants are diagnosed with major depression, and that's what we would hope to find. But the slope of these lines actually differs depending on diagnostic interview. So in the dark black line here, we have the semi-structured interviews, which are thought to be the best and the most valid, and these have the steepest slope. So the strongest relationship between symptoms and diagnosis. Now, the fully structured interviews, which mean they may be less valid because they don't have that clinical judgment component. Well, we actually found some results in line with this theory. So their slope is a little bit reduced. So it's a little bit flatter here. And this means that there's more diagnoses on the lower end of the symptom scores and fewer diagnoses at the higher end of the score. So they're not so good at distinguishing between individuals with and without depression. And just one particular interview that's called the mini, and this is a very brief interview that was designed to be brief at the cost of being over-inclusive. And that's exactly what we found. Regardless of the depressive symptom severity, the mini had about twice the number of diagnoses compared to the other interviews. And this actually translates to differences. So this difference in the performance of interviews translates into differences in the apparent accuracy of the screening tools themselves. So here's just one figure from our IPDMA analysis on the accuracy of the PHQ-9, which was published in BMJ. And here you can see the ROC curve looking at accuracy at different cutoff points of the PHQ-9 compared to different reference standards. So we can see that the PHQ-9 appears to be most accurate when we compare it to the best interviews. So when we compare it to the semi-structured interviews, it looks best. And when we compare the PHQ-9 to the other types of interviews, the PHQ-9 looks less good. And now again, these are not three different screening tools. This is one screening tool compared to three different gold standards. And what we're finding is that if you're comparing a screening tool to an imperfect gold standard, then your screening tool is not going to look as good. And this is because you're comparing to a little bit of noise rather than comparing to a true diagnosis. So it's really important that you have the best type of gold standard when you conduct these studies. Okay, so moving on, the next study looked at using the PHQ-2 as a pre-screen for the PHQ-9, and I haven't spoken about the PHQ-2 yet, but I will show it on this slide. So here we have our PHQ-9, again, the 9 items, multiple choice answers. And our PHQ-2 is actually consisting just of the first 2 items from the full PHQ-9. And this PHQ-2, it's sometimes used alone, so just asking these 2 questions, but in the clinical context, it's actually often used in a sequence where the PHQ-2 is used as a pre-screen for conducting the rest of the PHQ-9. So you start off by asking the first 2 questions from the PHQ-2. If you score negative on the PHQ-2, you stop right there, negative screen. And if you score positive on the 2 items, then you receive items 3 through 9, and then you get your full screening result based on the responses to all 9 items. So again, this is clinically how depression screening with the PHQ-9 is done in clinical practice, but it has not previously been possible to evaluate this in a meta-analysis because many of the PHQ-9 studies don't report accuracy for the PHQ-2. Even if they had the data to do so, they didn't report it. So only 1 or 2 primary studies evaluated the sequence. However, with IPD in our DEPRESS project, we have all the item scores for each participant. So we can reconstruct their PHQ-2 score and we can look at the sequence and create their sequence, even if it's not how it was done in the original studies. So we can calculate scores for their PHQ-2 only, the PHQ-9 only, and the sequence and evaluate 3 different approaches. And this is exactly what we did in a large meta-analysis that was recently published in JAMA. So we used the data from our PHQ-9 IPD project. We constructed their scores from the PHQ-2 alone and in combination with the PHQ-9. And we looked at the accuracy, and we also looked at the resources that would be required. So we looked at the reduction in the number of patients who would need to complete the full PHQ-9 if we could use this PHQ-2 as a pre-screen to determine who receives the rest of the interview. So here are the results, and we're going to compare all of these different combinations to just doing the PHQ-9 alone, which is, again, this is just asking those 9 questions. So if everybody receives the PHQ-9 and you use this cutoff threshold of 10, again, which is the common or standard threshold, the sensitivity and specificity are 86 and 85%. Now, if we use the PHQ-2 alone, it's not so great because either sensitivity or specificity is going to be compromised. So using a cutoff threshold of 2 on the PHQ-2, our specificity is about 20% off compared to using the full PHQ-9. If we may use a higher threshold of 3, then our specificity is a bit better. It's only 1% off, but now our sensitivity is affected. So, we have to compromise one or the other. However, there's this magical balance point where if we use the PHQ-2 with a cutoff threshold of 2, and then in the positive PHQ-2s administer the rest of the PHQ-9 and use a cutoff of 10 for the rest of them, we get sensitivity and specificity pretty close to using the PHQ-9 in everyone. So the difference is a 4% reduction in sensitivity and a 2% increase in specificity. So again, pretty similar accuracy. And what's really great is that only 43% of individuals need to even complete the full PHQ-9 because, about 60% are going to screen negative on the PHQ-2 and stop right there. And then the other 40% only need to complete the rest of the items. So this is a little bit more efficient than using the PHQ-9 fully in everybody. So that's one way that the screening tools can be used in a more effective way. And another method that can be done in the IPD context, which we have not yet started, but it's up next in our list of projects to do, is to use prediction models. And I'll show you the general concept of this. So right now, let's assume that these are, let's say, 6 individuals with progressively more severe depression symptoms. We have this binary approach of negative screen, positive screen. But rather than lump these people together, we can conduct prediction models and look at specific scores. So looking at each person, if someone scored a 3 or a 9 or a 10 or a 12 or a 27 on the PHQ, get their specific score into the model, and also put in other variables that may be related to either prevalence or the accuracy of the tool. So getting these richer models that can give more personalized risk estimates for depression. So that's in line for our team to do. In order to get there, so we're not ready to do these prediction model analyses yet, even though we do have large samples. We're still collecting more data to have even larger samples. And we also are trying to develop methods to correct for imperfect reference standards. So this, our gold standards that are maybe not quite so gold. And rather than having to restrict our analyses to the best interviews or stratify, if we could come up with correction methods, then we can put everyone into analyses and have more data. And in terms of these clinical characteristics that we want to include in our models, we have to figure out ways to address the missing data issues, because a lot of the primary studies didn't collect a lot of clinical covariates. So a lot of them did collect age and gender and setting and things like that. But in terms of specific medical comorbidities, it's very sparse between the studies. So we want to figure out the best way to try and recover this information and have, again, more data for our models. And finally, just one last study. Again, this is taking a step away from depression screening, but looking at mental health assessment. We did some studies to estimate depression prevalence based on the % above screening tools instead of using the clinical diagnoses. And well, there is no way to do this. It's still a problem, but I'll show you the study that we did to try and address that. So what we did in this study, which was published in the Journal of Clinical Epidemiology, is that we took all the data from our PHQ-9 IPD database, and we compared the prevalence of depression based on a PHQ-9 score of 10 or greater. So again, using the standard screening threshold. So prevalence based on the SCID, which is a diagnostic interview. So this is the true major depression status, and this is the one estimated by using the screening tool and cutoff. And we also assess whether maybe using an alternative cutoff score could better estimate prevalence. So maybe the cutoff threshold that's best for screening is too low, and maybe a higher threshold will be better for estimating prevalence. So we had about 10,000 participants and over 1,000 depression cases from 44 studies combined for this analysis. And we estimated prevalence based on, again, PHQ-9 cutoff of 10, SCID major depression. So using the SCID, the true prevalence of depression was 12%, but using the PHQ-9 and a cutoff threshold of 10, the prevalence was about double. So we have 25% compared to 12%, or the difference of 12%. So versus relative, we have about doubling, and absolute difference about 12%. So really, PHQ-9 cutoff of 10 should not be used to estimate prevalence. Okay, so we can't use that cutoff. Can we use another cutoff instead? So we looked at every possible cutoff threshold, and we found that using a cutoff threshold of 14, overall, it's pretty good, and it provided pooled prevalence that was pretty close to the SCID prevalence, so a difference of only 0.5%. So overall, it works. However, too good to be true. There's really too much heterogeneity at the individual study level to be able to use this in practice, and just to quantify this heterogeneity in the 44 studies that we had in our database, the differences in the prevalence based on a cutoff threshold of 14 versus the SCID interview at the study level could be underestimated by 20% or overestimated by 30%. So this is really huge. If you have prevalence ranging from 10 to 15%, and now you're going to overestimate it by 30%, that's very much giving you the wrong prevalence. We also determined what the prediction interval would be for a expected difference in a new study. So not the 44 in our meta-analysis, but if we were to conduct a new study and try and estimate prevalence using this cutoff threshold, and still we could be over or underestimating by up to 15%. So not possible to estimate prevalence using screening tools, not using the screening threshold, not even using a higher threshold, just not the right way to estimate prevalence. And we've conducted similar studies for other depression screening tools, so the EPDS and the HADS, and similar results. That's not possible to use a screening threshold or any other threshold from a screening tool to estimate depression prevalence. Okay, so I know those 6 studies in 45 minutes is probably too many, but maybe you've caught some of it, and I'll just recap it pretty briefly before we wrap up. So using an IPD meta-analysis approach, we have shown that selective cutoff reporting in individual studies on depression screening accuracy generates biased accuracy estimates in conventional meta-analysis. So if you are conducting a primary study, don't just publish the accuracy for the results that performed well. Please publish results for all possible cutoff thresholds. As well, data-driven cutoff selection methods lead to substantial variability. So when we see differences in accuracy and optimal cutoffs in small primary studies, they may really be due to the small samples themselves rather than to specific study or participant characteristics. So if you see an accuracy study done in a very small sample and they're making claims about the optimal cutoff threshold or what the accuracy is, just be a little bit wary of that and rely more on large meta-analyses than on small primary studies. In terms of gold standards, not all diagnostic interviews for major depression are equal, so don't just assume that the semi-structured and the fully structured and the different interviews are done the same. And maybe maybe worth investing in a more rigorous diagnostic interview if you are conducting a study in this area. In terms of the screening tools themselves, so we've just done some preliminary work to show that perhaps there are ways that we can use the existing screening tools more effectively. So for instance, using the PHQ-2 with a cutoff threshold of 2 prior to administering the full PHQ-9, it may be resource efficient because about 60% of participants won't even need to use to answer all 9 of the questions. They can just stop after 2. So we could save some resources that way. As well, prediction models, which we have on our list of projects to do, can be used to provide even more fine-grained risk estimates, so providing more information from the screening tools that exist. And finally, and I hope that I can't say this enough times because every so often I keep seeing papers and they come out in JAMA and Lancet and really high impact journals looking at prevalence of depression in whatever population, and they're using screening tools rather than diagnostic interviews, and they're calling it prevalence. And just stop, like big stop sign, screening tools cannot be used to estimate disease prevalence. All right, so I think we're pretty much at the 45-minute mark. So just takes a village to do an IPD project. So thanks to the DEPRESSD steering committee team and our local project team of, again, over 20 students and staff, the more than 350 data contributors that have provided data without which we wouldn't even have these great databases, as well as funding for both myself as well as the project from both CIHR and FRQS, which is our Quebec provincial funding agency. So thank you all for listening, and I'm happy to take any of your questions.
Great. Thank you very much, Thank you very much, Brooke. We have quite a few questions sitting in here. A number of them from our own internal medicine specialist, Tom Perry. I wonder, Tom, instead of me summarizing your questions, do you want to ask Brooke yourself? Maybe not. Okay. So Tom asked initially, he says, I find this extremely interesting, but does the error in attributed prevalence apply similarly to all other chronic conditions promoted by the literature as critically important health issues, such as chronic pain, chronic headache, migraine, etc.?
That's a great question. I don't know the answer to it because most of my work has been in mental health epidemiology and looking specifically at this issue with depression screening tools. I would imagine that anytime you have, like a screening tool or a quick way of measuring something, that it's not going to be the same, it's not equivalent to a diagnosis. That would be my quick answer. But yeah, again, I don't know other areas.
Right. And Tom also noted that you had a Venn diagram that shows, say, 11,000 major depression cases. And he asks, do you mean to imply that they truly have major depression or that they're labeled from the rating scales as having major depression?
So that anytime in my projects where I talk about major depression, that is based on the diagnostic interview, which again, it could be one of those really the better interviews, such like the semi-structured interviews that have that clinical judgment component, but also the ones from the less perfect. So the imperfect reference standards are also in those counts. So for some of our studies, we restricted. So like some of the that last study looking at prevalence, we only looked at, we want to kind of avoid the issues related to imperfect reference standards, and we only used a subset that had the best type of reference standard. But yeah, our database, it's about 1/3 semi-structured, about 1/3 fully structured, and 1/3 this mini interview. So we do have a mixture, and those counts are all, as long as it was from a interview, we call it a diagnosis. Whereas if it's based solely on a screening questionnaire or rating scale and not from clinical criteria, then that's not a diagnosis. So we kind of split those concepts of screening and rating scales versus actual clinical interviews.
Okay, great. So someone asks, having identified the included study, would you provide a cutoff time waiting for the individual data to be sent by authors? Like, how do you deal with issues around incompleteness, of how incompleteness of studies affect the underlying systematic review that you've done?
So it's a great question. And again, the literature is there's always more studies coming out. And I think it was our JAMA paper where we received positive reviews, and they're like, but can you also update your search? And that was crazy because it took us 4 years to get 60 studies, and then they wanted us to add in another like 40 studies. And we had we'd started to collect some of the data sets because our searches are ongoing. So we're always searching, but we're not always like proactively getting the new data sets. Like there's so much work that needs to be done. So at some point we have a cutoff in date, and we have version 1 of our database. And then eventually we had a version 2 where we had about 40 more studies that we incorporated. And so some earlier projects that we did were with, version 1 of our database. And then once version 2 was like clean and ready, then we started to use that one. And with that JAMA request, we actually had about 10 people on our team stop everything else that they were doing on every other project. And for 1 month, everybody worked just on harmonizing those data sets for that one JAMA paper, which again, this is really where like the village component comes in, and we did it. And we're like, we'll never do this again if a reviewer asks us to, because every other project that, we have funding for was just put on hold for a month. There was so many person hours of time just to update it for one paper. Another thing that you can do is a little bit of a quick fix is that you can combine the published, if you don't have the data for a study yet, you can combine the published results from those studies in with the IPD from the other studies and do that as a sensitivity analysis. And we've done that more recently. So we will say that there's about 10 studies we don't have yet, but adding that in didn't change our results much. But again, those studies that you don't have the complete data for, you don't have all of the data for. You only have what they reported. So, there's pluses and minuses, but we do what we can given the resources that we have.
Excellent. So one of the questioners asked, how do you distinguish screening from case finding interventions in general practice?
Well, I think it depends. It's the tool that's used. So if you're using a screening tool, so if you're using the PHQ-9 or the EPDS, which is often used in perinatal settings, if you're using a screening tool, then it's not a diagnosis. There's no threshold. Again, there's no way to call that a diagnosis. It is what it is. And if you use a clinical interview, then you can get a diagnosis. Now, that's not to say if you are doing a study on screening and you want to know if you're capturing people, that percentage of positive screens or looking at, continuous scores on a screening tool, that's still very important information and that's useful and that can be used in public health, but it's not case finding. It's not diagnostic.
Right. One comment from our own Tom Perry was congratulating you on using the term mathematically impossible. You've used it at least twice, he says. And he says, I often wondered about that in reports that claim high prevalence for everything. And I've never heard anyone point that out before. So good job. So one person asks you, may I ask what method or tool you suggest to estimate the prevalence instead of screening tools?
So I could spend a whole hour just talking about that. Basically, there's the best option that I would recommend, if I can just say one thing, would be a 2-stage sampling. So what you would do is that you would start off by administering, let's say you have recruit 1,000 participants, administer a screening tool in all of them, and then use some threshold. It could be a screening threshold or a higher lower threshold, and then administer a robust, clinical interview to those that score above the threshold, and also to a small proportion of people that score below it. So let's say about, everyone who scores 10 or higher, give every one of those a diagnostic interview. And then out of the people who score negative, give, let's say, a random 10% a diagnostic interview. And then you can use statistical weights to correct for that. And then you'll get a true prevalence estimate based on a proper method. Because it would be way too expensive to conduct, 1,000 diagnostic interviews. So if you can do a sampling approach where, everybody over a cutoff threshold gets the interview and a small sample below it, you can't just do the positive screens because you are going to miss some people, and you can't just do the negative screens, of course, then you're going to miss people. So you need, you need a representative sample, but if you weight it and get a higher percentage of people above and a lower percentage of people below, and then you just use the inverse probability weighting and then pull it together, then you can get a valid estimate.
Mm-hmm, mm-hmm. So one more general question someone asks, do you know what percentage of doctors in Canada use the screening tools and or diagnostic criteria when they're diagnosing major depression? I
don't know what the percentages are. I do know that the Canadian Task Force for Preventive Healthcare does not recommend depression screening. So I know it's not recommended at the government guidance level, although I personally know some, family physicians who they are encouraged in their clinical practice by their supervisors to do screening. So sometimes, what the guidance people say is not necessarily what a hospital or a clinic is going to have as their rule. And again, this is what I've heard offhand from some friends. So I don't know what the percentages are, but I know it's done. And again, I think there still is, don't just throw these tools out. There's still a lot of important information in them, and you can use, again, using them to track depressive symptoms over time, or using them to guide a conversation, which is not the same thing as depression screening. But if you could, take these 9 items from the screening tool and then have a conversation with your doctor. So there's really some great uses of these tools. So don't just I hope you don't come away from this talk thinking that, these tools are just be shoved in the garbage. There's still some use to them. Just be careful how you use them, and don't prescribe someone an antidepressant because they screen positive. That would be one thing that I hope you would take away from this.
Right. So I just one final comment, because we're kind of at our end of our time. And it's my question actually, is that I'm curious how you mentioned the Canadian Task Force on Preventative Healthcare, which is, the large group of independent researchers that look at screening in Canada. And have they come out specifically against any form of depression / mental health screening?
They've flat out very objectively state, I don't remember what year was their most recent guidance, but it says that they do not recommend it. There's no evidence supporting the recommendation of doing it. Now, the positive spin is that hopefully, down the line, if we find these better ways to use the tools and maybe the prediction modeling, and maybe once we have these prediction models, they'll be better, and then we can do a trial. And then if a trial shows that it is effective, then maybe the guidance will change down the road. But at the moment, they very clearly do not recommend it. In the States, it is recommended, and it's actually very strongly recommended in the States, but Canada has a different opinion. They look at Canada and the States, their guidance committees look at the same set of literature and the same studies, and they can come out with opposite recommendations, which is, again, it's a whole other topic for discussion.
And just briefly, Brooke, before you sign off, what are you looking at next? I mean, your research has clearly brought you to a certain point, but what's down the road? Many things. One of them is this, getting to be able to do these prediction models. Another thing is on the method side. So these small primary studies that have, a ton of variability. We're working on a really interesting project to construct confidence intervals for an optimal cutoff threshold. So if you're going to conduct a small study, and let's say if you only have funding for 200 people in your study, and then you find an optimal cutoff of 6, but then if you put a confidence interval around that 6, and you could say, maybe it's 6, but it's 4 to 9 or something like that, then that would at least let people do research that they have the funding for, but then put out information that's not so, this is the optimal cutoff in this small group, but saying that, we found a 6, but the confidence interval, and then just, allowing for that variability to be more transparent. So that's an exciting project that we have, as well as trying to figure out how to correct these imperfect reference standards so that we don't have to discard the data that have it. I mean, the imperfect reference standards, again, they're not trash. They're still pretty good. They're just not as good as other ones. So if we can find a way to, mathematically adjust for that, then we'll have even better data. I want to thank you, Brooke, on behalf of the Therapeutics Initiative for joining us. This has been fascinating and eye-opening. And thanks again for joining us. And we look forward to seeing you again.
Thank you for having me.